Now I would like to call upon Dr. Shrikant Mukewar, sir, Director and Senior Gastroenterologist, Midas Hospital, organizing chairperson for today's event. He will be speaking on management of gas and bloating. I would like to call upon Dr. Zawar, Dr. Atul Rajkondawar, Dr. Sudhir Gupta, and Dr. Piyush Marudwar to chair the session, please.
Good morning, friends. In fact, when this topic was discussed, that whether should we be discussing this topic, there was a lot of debate that should we take this topic for a discussion or lecture or should we not. But I have delivered the first lecture on this topic about 3 years back. And then I have realized that such a common problems, and there are some things which need to be learnt about these common problems. So I am going to ask you the questions. You have a voting pad on your table. So I am going to ask you 4 questions. Please answer them. What is the total volume of the gas in the GI tract? 0 to 100 ml, 100 to 200 ml, 200 to 300 ml, or 300 to 400 ml. You have to vote once now you can vote. It has already started. Oh, that's great. So I am excited to see that the majority are right, that it's 100 to 200 ml of gas in the small intestine. The next question. Which gas is the commonest in the GI tract? Whether it is oxygen, CO2, hydrogen, nitrogen, or methane. So, the audience are very learned. Nitrogen is the commonest, followed by hydrogen, followed by oxygen and CO2, because the CO2 diffuses. Next question. You are right, nitrogen, hydrogen. Which part of the GI tract has more gas? Esophagus, stomach, small intestine, and large intestine. Correct. Large intestine is the one which has more gas. Very nice, very nice. Very learned audience. Next. Measuring gas in those complaining of gas, what would be the percentage those who have more gas? 25%, 50%, 75% or 100%? I think this is little tough. Let's see. No, the correct answer is 25%. So, see, majority of the other people may have excessive perception of the gas secondary to. Now, what is the intestinal gas? 100 to 200 ml, Composition is nitrogen, hydrogen, oxygen, CO2, dynamic process which is under tight control. You can measure the intestinal gas by two techniques, either by CT volumetry or by argon gas, which is pushed from orally and measured per rectally. This is to show you that this is a CT image which shows that when the person is supine position, you see that majority of the gas is towards the anterior abdominal wall and the colon is the main source. What is bloating and what is distension? Bloating is subjective, distension is objective. Any person, you have so many patients in clinical practice, gassiness, fullness, trapped gas, filling of pressure, all this is there. This in objectively, people complain that when we take a abdominal girth before and after meals, our abdominal girth increases and that happens. This is what is called as abdominal distension. 60% of bloating will complain of abdominal distension. These are very common in clinical practice. Now, what is the prevalence? Why this topic is important? Because 16 to 31% of general population have this and more with functional GI disorders. Many patients with irritable bowel will complain of bloating, fullness, gas. So that's why this is important. Now remember the teaching for us, 5 F's: flatus, feces, fluid, fat and fetus. So all these you must rule out. You must rule out. Remember these 5 F's that you have to rule out when the patient complains of abdominal distension. We have patients who have been described as functional dyspepsia and turns out to be obstruction or ascites. So that has to be ruled out. Pathophysiology is little complex. As I said, you have to rule out organic. Only 25% have more gas. The dietary factors, food and drugs are important. Bacteria in the small bowel is an important factor. Normal persons, the small intestinal bacteria are not there. But when you have SIBO, bacterial growth in the small bowel, that leads to complaints of gas. Constipation is a very important factor for gas. Abnormal brain-gut axis and motility. So it's a common misnomer that gas is increased in all the patient. It is only increased in 25% of the patient. As I was telling you, normal small intestine, almost less bacteria. SIBO is small intestinal bacterial overgrowth. Fermentation lead to gas. Food intolerance and altered bacterial flora are the 2 factors. Abnormal motility. Patients with gastroparesis can also complain of bloating. Pelvic floor dysfunction, as has been told by Shubhankar, is also associated with delay in the transit. And the important in clinical practice, one has to recognize why the distension occurs. When you have a normal amount of gas, what happens? When the normal physiologically, when the gas comes in the bowel, the diaphragm goes up. As a result of which the abdominal wall is not distended. But in patients, those who have abnormal viscerosomatic reflux, the diaphragm goes up and, the diaphragm doesn't go up, as a result of which the abdominal wall descent comes forward. So there is a abnormal viscerosomatic reflux leading because of impaired movement of the diaphragm upward, which leads to pressure on the anterior abdominal wall. Many of these patients have visceral hypersensitivity. There are studies by which you push the balloon in the colon and find out. The person doesn't know whether what is the amount of gas which is put. If you, in a person who has this abdominal bloating distension, he will complain of gas when the organ is distended, while the normal person will not complain. So what I mean is that the sensations are increased. Again, stretching, that the organic etiologies have to be stressed. SIBO, small intestinal bacteriogrowth, patients with pancreatitis because of maldigestion, surgeries, celiac disease, gastric outlet obstruction, ascites and malignancies have to be ruled out, but majority of the times it is the functional problems which are very important. Now, how do you proceed? First, you have to ask whether it is food related or bowel related. Whether you have to ask whether there is surgery, any medications which are going on. Bloating with alarm symptoms, they must have celiac serology, endoscopy and anorexal functional studies. Breath test is a simple test. Now, what is the principle of breath test? When you take glucose, it is acted by organisms in the intestine and the hydrogen is produced which is picked up by the breath. So in a normal person, when you give glucose, it takes more than 3 hours for the hydrogen to be produced. So if you have bacteria in the small intestine, what happens is the hydrogen is produced before 3 hours and that leads to positive breath test. What is the treatment? The most important treatment is low FODMAP diet, probiotics, antibiotics if you suspect that the patient has small intestinal bacterial overgrowth. Actually, what we have done is that we have given you the charts of low FODMAP and high FODMAP diet in your bag, registered bag, so you can go through it. These are the foodstuff. High FODMAP should be avoided. Low FODMAP are to be advised to the patient. So I'll just discuss about when you have a patient with chronic belching and bloating, are there alarm symptoms? Yes. Then they should go labs like celiac serology, endoscopy and imaging. When no alarm symptoms, whether they are bowel related, yes, then if the constipation, that should be treated. If diarrhea, that should be, found out. If there are no symptoms which are predominantly bowel related but diet related, then institution of low FODMAP diet. If improvement continue, if no, you can give an empirical treatment of antibiotics, and if no, then probably you can investigate. Belching is another problem, and belching is oral expansion of air from the GI tract. Either it is audible or silent. Physiological, when it comes from the stomach 30 times a day, supraglottic is 13 times. Many of these dyspeptic symptoms, it is common. What happens, like a patient is sitting in front of you and he is belching again and again. So your diagnosis is that this is supragastric belching. What happens? There is a contraction of diaphragm. As a result of it, there is a negative pressure. This leads to sucking of air inside, and because of contraction, the air is expelled out. This is the supragastric belching. And what is gastric belching? Gastric belching is a physiological thing where the air goes out and during the transient LES relaxation. So this supragastric belching is voluntary, this is involuntary. This is non-physiological, this is physiological, often requires medical and psychiatric attention, rarely requires, does not occur during sleep, can occur during sleep, usually have supragastric have high frequency. I wanted to show video because the time doesn't permit me. So history of excessive repeated belching, impedance is a good technique. Now, I would not go into the details of impedance, but in the gastric belching, it is from below upwards. This is impedance. Impedance is a method of resistance of finding out air and fluid, while in supragastric belching, there is inhale and it goes out. And the same is depicted on manometry. So, treatment, supragastric belching, behavior disorders, psychoedulation, psychiatrists may help, speech therapy and cognitive therapy. So, thank you for this patience listening, and I thank Chairperson Dr. Sudhir Gupta, Dr. Atul Raj Kondawar, Dr. Jhawar and Dr. Piyush for gracing this occasion. Thank you.
Thank you, sir. It's a very complex topic with multiple etiologies and very etiologies, and you have explained it very well. Only thing we should keep in mind that this may be an overlapping symptom. It should not be missed that if it is a cardiac in origin. And we have seen in our practice that at times the cardiac symptoms are misinterpreted as bloating, and this is the situation which should be properly evaluated. Otherwise, there are many remedies when the patient should be referred to the gastroenterologist in general practice. That is another. Can you give some hints where the patient should be referred to the gastroenterologist?
I think if they have alarm symptoms like weight loss, you feel that there is anemia, weight loss and the things like that, then I think you need to investigate these patients.
It was a complex topic which was very well narrated by Dr. Mukewar. Really, majority of the patient which a clinician sees, about 30 to 35% of the patient who presented with either bloating or distension of abdomen. But I asked one question from Mukewar, how to differentiate between a IBS, a distension of abdomen and bloating of abdomen?
Yeah, that's a good question. Now, if you see functional bloating, actually, in fact, I had taken that Rome 4 definition. Whenever the bloating is a predominant symptom without any bowel problems, when it is a long-standing, say for a period of 6 months with the onset and the 3 months at least 1 or 2 times in a week, that is defined when it is a predominant symptoms. But when you have the other symptoms of the bowel, like altered bowels, which are more predominant and bloating is a secondary symptom, then we say that this is a patient with IBS and the bloating is accompanying it. Yeah, Atul.
Really very well topic explained nicely, but are there questions from the house? Yes.
We have to make it more interactive. But I would like to again tell that any patient with bloating, find out the correlation between diet and bowels, and if the patient is constipated, treat. If the patient is not constipated, give FODMAP diet, low FODMAP diet. If the patient is not responding, find out whether the patient has small intestinal bacterial overgrowth, and ruling out organic disease is very important. Ruling out organic disease.
In that, sir, wheat is considered as
celiac.
high. So, whether patients accept that, not to take
basically
wheat.
when we diagnose that the patient is intolerant to wheat, we normally stop the wheat, but the diagnosis is done that patient has celiac disease, that your tissue TTG is positive, endomysial antibody is positive, or whether your D2 biopsy shows evidence of celiac disease, then only the wheat is stopped for a while. There is an entity of gluten intolerance where you may not have celiac disease, but intolerance to wheat. In that case, you can give a trial because it's very difficult to diagnose that condition. You can give a trial and find out. Majority of the times, what we advise to a patient is milk and milk products should be avoided. All pulses should not be given. Should be given the sweets, beverages and the aerated drinks should not be given. So this is regarding their diet plan. And more happens with red meat and other things, you know. Thank you.
So we would like to know about.
Sir, any correlation with hiccup? Sir, any correlation with hiccup?
Hiccups, yeah, I'll answer both the questions. The first comes to FODMAP. FODMAP is a very complex term. Fermentable oligo disaccharides, monosaccharides and polyols. That's a full form of, so basically the fermentable carbohydrates which are more is FODMAP diet. I should have explained that. And hiccups is involuntary contraction of the diaphragm. And whenever a patient with hiccups comes to you, you have to rule out certain things, whether the patient has renal failure, whether the patient has reflux esophagitis, which is commonest, anything subdiaphragmatic, abdominal distension, liver abscess, gastric outlet obstruction, they can give rise to hiccups. They are also seen in pulmonary conditions, ischemic heart disease, central cause of hiccups and functional. So these becomes, hiccups are, actually in fact I wanted to discuss hiccups also, but then it would have been too long. So
thank you,
thank
sir.
you.
It was a wonderful talk and you covered in such a short duration of time. I think we have exceeded the time. Only one thing is there are newer tests like electrogastrography, like ECG, we have EGG, we have tachygastria, bradygastria, like ECG. So certain conditions such as gastric dysrhythmias, we can diagnose with that, and scintigraphy, we can diagnose gastroparesis.
Yeah.
I think we have exceeded the time, so I think...
Yeah, actually, all these electrogastrography, EGG, is a newer terminology, but then it has not come in clinical practice. It is still yet in the research state. So, and these conditions, whatever tachygastria and are not very common in clinical practice, you know.
Thank you very much.
Thank you.
We close this session now.
Thank you. Thank you.
Thank you, sir.